This week, we have somebody on the podcast that's been a recurring guest on this podcast since its inception in like 2014. His name is Mike Stone. He's an emergency physician out in Portland, Oregon. And although he does everything super well, what he does particularly well is nerve blocks. And that's what we're going to talk about today. Now, before we get started with the podcast, I have two announcements to make. I think that they're kind of a big deal, and I wanted to share it with you guys. It's basically the reason why we have been maybe not producing as much stuff consistently as we would like, and it's because we have a couple of projects that we've been working on, and I wanted to share those with you guys via those announcements. Now, I'm going to publish this podcast, and in the next podcast, hopefully I will have part one of our major announcement all figured out that I'll be able to share with you guys about the new direction that the ultrasound podcast, 5 Minute Sono, and ultrasound of the week are going to all be taking together. So stay tuned in subsequent podcasts. So after this one, where hopefully I'll have everything figured out. In the meantime, enjoy this interview I did with Mike Stone. Now, at the beginning of the interview, I was, looking through it, and I realized I was kind of like gushing a little bit. Mike Stone is actually one of my mentors, one of my role models, and I remember being a resident and just being in awe at how good this guy was at teaching, and very honored to sit down with this guy. Check it out.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound. Hello, I'm Jacob Avila of the Ultrasound Podcast, and today I'm like, oh my God, super stoked. I have one of the guys that I remember meeting when I was like, it was either a first or second year resident at Castlefest. This guy was one of the best hands-on teachers and one of the best lecturers I had ever seen in my life, and nerve block guru. And Mike, you're in Portland, Oregon. You're an ER doc there. Is that right?
That's correct. Yeah. Out in Portland, ER docking.
Awesome, man. So there, I mean, you obviously are going to run into situations where nerve blocks are going to be useful. So you're obviously, still kind of in this world. Now, you are a few years ahead of me in your career and in your training, and I want to be like you when I grow up. What is some advice that you have for me and really anybody else that might be interested in bringing their ultrasounding to the next level, specifically talking about nerve blocks, which are things that I think are so important in the emergency department?
Yeah, I mean, there's a bunch of great content out there on learning blocks, and I think we'll either just link to that or feel free to go online and use the Googles and the YouTubes to find some good content. I thought it'd be fun to talk a little bit about stuff that I didn't know 10 years ago, 15 years ago when we started messing around with regional anesthesia in the ED that I've learned since and that I kind of wish that I knew back then. So we can just kind of work our way down a list of things if that's cool with you.
That's perfect. That's exactly what I want to do.
Awesome. So I guess we'll start with safety. So when we first started doing blocks about 15 years ago in our emergency department in California, we were really using them preferentially for the management of injection drug users with large cutaneous and subcutaneous abscesses. And the sort of model for how we would care for those patients prior to doing regional was either just do it under local with some pain medication, which, for a sizable abscess really isn't compassionate and is right. pretty uncomfortable. Or we would do procedural sedation and deep sedation for drainage of abscess. And the problem was that in these sort of like, OG injection drug users who'd been at it for 15, 20 years, they just had nothing for vascular access. And even with ultrasound guidance, you really couldn't find like a good peripheral IV. So it wasn't unusual to see folks get, single or triple lumen central venous catheters placed so that they could be sedated so that you could drain their abscess so you could pull their catheter after the sedation and then discharge them. Oh, and it just seemed like a flawed system that less than ideal. So we started experimenting with regional with some guidance from our local experts from anesthesiology. And I think really the first blocks we were doing regularly were supraclavicular brachial plexus blocks and interscalene brachial plexus blocks. And like I look back at it now, and we were really fortunate that we didn't have any significant safety issues that arose, because we were doing these in patients without peripheral vascular access. And I think if you look at the ASA guidelines, the ASRA guidelines, really having an IV, having the patient on a cardiac monitor, being able to monitor them for signs of either allergic reaction or local anesthetic toxicity is pretty critical. So I'd say something that's changed in my practice since starting blocks is if I'm placing a block on somebody with and it's proximal to the elbow or it's proximal to the knee, those patients have IVs, and I'm putting them on cardiac monitors. I can't say that I do it for your average forearm nerve block for a hand injury or an ankle block for a plantar foot injury or foreign body. But everything else, I'm getting vascular access. So that's something that's changed, and I don't know how much people do that. I'm curious in sort of the knowledge translation into emergency medicine, how many of us are placing peripheral IVs for blocks, and I'm sure it happens. There's always going to be a circumstance where for whatever reason it happens before an IV goes in, but I think we should probably try and avoid that if we can. I think it's hard to defend, and even more importantly, like if you have an adverse reaction to your anesthetic, you're going to be scrambling to get vascular access when it's something that you should already had present.
So it's kind of like, it'd be kind of like doing a sedation without making sure that your BVM, your suction set up, and you have any kind of reversal agent that you might need, not having it in the room. That's kind of the same thing, if I'm understanding correctly, that we're doing if we don't, when we're doing a proximal block, have them on a monitor and have IV access, not assuming something's going to go wrong necessarily, but just being ready for it in case it does.
Well, and, absolutely right. And you think about like how we prepare for everything, right? You get set up for to do a rapid sequence intubation, and you've got all your staff there. You've got hopefully respiratory there. You've got your BVM. Ideally, you have sort of like plan A, plan B, plan C. And if you're a really good communicator, maybe everyone in the room already knows that if you're going to go ahead and paralyze and take a look and you can't see, your next step is going to be this. And then if that doesn't work, your next step is going to be a supraglottic airway. And if that doesn't work, you're going to move to a surgical airway. And everybody kind of understands the sequence. I mean, how many like little plastic bags and kits do we break out before we intubate somebody? And, 99% of the time we don't end up touching anything except for whatever our first line approach was. I think it's the same thing with planning for regional. Obviously, the consequences are less likely to be, that critical in terms of seconds. But if you're doing a block and somebody starts seizing from their local anesthetic toxicity, you don't want to be searching for an IV to give a benzo, right? You want to have something ready to go. So that's one thing. And I guess kind of tangential, but adjacent to that is I think most people are familiar with local anesthetic systemic toxicity. If not, the American Society for Regional Anesthesia has an awesome checklist for it that's free and online that you can get. But I think everybody pretty much knows, you're going to manage seizures with benzodiazepines, and then cardiovascular collapse is really managed the same as any other cardiac arrest in terms of ACLS protocols, with the exceptions of two things. One, not that we do this much anymore, but don't give lidocaine for arrhythmias if the reason that you're seizing is you've got a local anesthetic reaction. And then two, lipid emulsion therapy, right? So I'm curious, Jacob, do you guys stock lipid emulsion in your ED?
We do. I'll be honest with you, I don't know exactly where it's located, but I have asked our pharmacist specifically, how long will it take us to get last antidote, so lipid emulsion therapy, to a patient room. And we did a drill once, and I think it took us 6 minutes, 5 or 6 minutes, which is a little bit too long, to be honest, but it's not like it's on the other side of the hospital.
Yeah. Yeah, I mean, I think it's great to go through the process of kind of seeing how you can get it to the bedside in your department. So I did something similar. We have ED pharmacists from I want to say like noon to midnight, or maybe 2 p.m. to midnight. And
Nice.
maybe I don't know, 6 months ago or so, I had a trauma patient who was a teenager with a really like probably the most deformed looking femur fracture I've ever seen. It was like 90 degrees at the mid femur from a football,
Oh my goodness.
just a freak football accident. And we that kid came in. We were seeing him with the trauma service. We went ahead and just did like super fast assessment and primary, secondary, and then sedated him to straighten out his leg. So we took care of that, and he was reduced, but obviously woke up from his propofol and was in considerable pain. And
sure.
The trauma service asked if I'd be willing to place a block for them, which was super appropriate, and we did. And then I was walking past the ED pharmacist on the way back, and I thought, I actually don't know where the intralipid is in our hospital, where we keep lipid emulsion therapy, and how long it would take. And I said, Julie, I just did a femoral nerve block on this teenager in room 18. I think he's developing local anesthetic systemic toxicity. Can we get some lipid emulsion? And she kind of looked up and was like, "You're kidding, right?" And I was like, "Let's pretend I'm not kidding." And she was like, "Okay, cool." And
that's a good idea. Like a little drill.
Yeah, and it was just it was a low pressure sim. I didn't maintain my character. I told her that it was. I mean, she knew it was hypothetical. And she came back to me, I want to say like 9 or 10 minutes later, with a bag of lipid emulsion therapy, and was like, "This process is way too long. I'm going to readdress how we do this." And maybe a week later, I got a text message from her that it's stocked in the Omnicells in the ED now. That there's awesome. 2 of the trauma rooms have lipid emulsion therapy. So now it's a less than a minute process. But I think it's worth. I don't know that it needs to be at the bedside. It's a rare event, but at the same time, it's something that you don't want to be scrambling around the hospital for. Yeah. So I do think it's great to do a drill, and it doesn't have to be something super formal. You can just ask either your charge nurse or your pharmacist, if you have one, and say, "Hey, I need this right now. Let's pretend I need it right now. My time starts now. Tell me how long it takes to get it." And then if I think realistically, if it's more than like 5 minutes, I think you need to be thinking about your process and reanalyzing it. Because what if it's 3 a.m. and you don't have a pharmacist, and they don't know how to go get, it's got to be something that's pretty easy to do. So along the lines of LAST, I would also say, having, using epi-containing solutions if it's appropriate for your block. I know you've talked about this. Having someone on the monitor, you may pick up on tachycardia or hypertension if you're unrecognized intravascular and you're giving something that has some epi in it. The other thing I can't say I wish I did this 10 years ago, because it didn't exist 10 years ago, is some of the apps. So there is a phenomenal app that I'm just going to make sure I have the right name of it before I go telling you and the listeners that it's called Safe Local, 2 different words, and it's basically
they're sponsoring you, right?
Yeah, exactly. So no, academic. I want to say that it's out of Johns Hopkins. It's free and open source, and I take no compensation from Safe Local. But it basically gives you bupivacaine, lidocaine, mepivacaine, and ropivacaine in both plain and epi options. You go ahead and select, let's say we want to do a bupivacaine with epinephrine block. You select that and hit next, and then it's going to ask you what percentage, and we'll say we're using 0.5%, and then next. It's going to ask you your weight of patient in either kilograms or pounds. So we'll go with like the mythical 70 kilogram person. And then sets comorbidities, which is nice because I think a lot of people don't think about adjusting their maximal dosage of anesthetic based on comorbidities. And in this, it's age less than 4 months, which I know you do a ton of regional in
All the time.
2-month-olds, Jacob.
All the time.
But realistically, age greater than 70 years, which we do every
A
single
lot, yeah.
time we're blocking somebody with a fractured femur, right? I mean,
Right.
outside of the teenager football accident, most of them are like, elderly, frail patients. So we'll say yes, severe renal dysfunction, hepatic dysfunction, advanced heart failure, or pregnancy. So we'll pretend that this person has, I don't know, they're an old person with heart failure. And it tells you continuous/repeat doses should be reduced by 10 to 20% due to reduced blood flow to the liver and kidneys. So got it. And then calculate dosage, and it's going to tell you max dosage per anesthetic, 38.25 mLs. So what I
Wow,
love about this
that's
app
easy.
is, number one, it's like super real time. It takes, if I'm not talking you through it, it takes like 10 seconds to go through and do. And it gives you not just a milligram dosage, which is what you get from most of the online sources.
Yeah, which is
And then you've got
confusing to have to like change it. Like, well, how many milligrams is in a milliliter and all that stuff, and it just adds another level of complexity.
Yeah, I mean, you're sitting there going, well, 1% is 100 milligrams per ml. Is that right? No, 100 per
I don't
10.
know.
It's 100 per 10. 10 per ml, I think, is 1%. I can never remember.
Yeah, it's too
And like
complicated.
I knew this when I was a med student, but I definitely don't remember it now. And getting an answer that's like 38 mLs
That's great.
of anesthetic as a peak, you can go ahead and kind of decide what you want to use, but you know that you're not exceeding it. And that's just, to me, that's the equivalent of just kind of like an extra timeout before you're doing a block. And I don't think it's necessary to do it if you're drawing up 10 mLs of local anesthetic of pretty much anything for an adult, right? I mean, you're going to do a forearm block. You're going to do, a super low dose or low volume interscalene block, or you're going to do a superficial cervical plexus block. All those, you're using less than 10 mLs. We would infiltrate that into the skin without thinking twice,
Right.
right?
Yeah.
I think you're within a safety dose. But once you're doing like a femoral nerve block or a large volume plane block or something like that, I think using safe local or something similar, if you have a preference, is a really cool way to go.
Nice. Yeah, that's a good tip. What about doing like a 2-man versus a 1-man? Because I know like using the extension tubing, like finger on the needle, is kind of nice. Like, what's your preference? Like, if you had all the resources that you could have and there was no issues with personnel, would you just do syringe on needle, or would you do extension tubing and have somebody else be pushing the anesthetic?
Yeah, so I definitely like kind of a hand-on needle versus a hand-on syringe technique. I think if you're holding the hub of the block needle between your fingers as opposed to having it on the end of a syringe, you just get a lot more dexterity. There's been some experimental sim, like tofu based ultrasound model studies looking at this, and if I remember correctly, I don't have the papers up in front of me, there's not much of a difference in terms of needle placement and success with either technique. Experientially, that's not how I've how my practice has played out. I find like that I have much greater ability with sort of fine tuning needle placement with hand on the needle itself as opposed to on a syringe. So generally, I like extension tubing. It's probably a good time to plug block needles in general. I think, again, if I go back 15 years, we were using just 1.5-inch Quinky needles, just the standard needles that come in like your IV cart or your procedure cart, just sharp tipped 22 gauge or 23 gauge needles. I think initially a lot of people liked using the like 25, 27 gauge needles because you figure it's a smaller needle, so it's probably safer, and may hurt less. There's a whole school of thought about using a large needle because if you get into the nerve sheath, you're less likely to place the needle into an actual nerve fascicle if it's a large needle. And there's people who
saying it might be safer.
I think it might be safer. There isn't any really compelling evidence about this, but I know that one of the big outpatient surgical center orthopedic meccas in Florida, where they do, you hear about, baseball players getting their rotator cuffs done at this institute. They do their interscalene blocks with like a 16 gauge block needle. And the idea is like, if the needle's bigger than the nerve root, you can't really put the needle into the nerve root.
Interesting.
Which,
so they're
if,
using like a blunt tip needle, right? Because my other thing was like, could you like cut it? So they're using a thick blunt tip needle.
Yeah, so thick blunt tip needle is their strategy. I think if you look at just, it's sort of like if you want to learn how to get like really lean and really yoked, you should probably take a look at what bodybuilders do.
Okay.
Right. I mean,
Sure.
there's
Yeah,
lots of
course.
like not great for longevity, lots of like flexibility issues. I'm not advocating a bodybuilding lifestyle, but
Right.
like those guys know what they're doing and those girls know what they're doing. They know how to get lean. They know how to build
Yeah.
muscle. If you're going to look at regional anesthesia practices, look at what the people who do lots of regional anesthesia do, because if it wasn't working for them, they would do something different.
Right.
And I don't think we need to move to like 16 gauge blunt tip needles, but you'd be hard pressed to find a regional anesthesiologist who doesn't use short beveled blunt tipped block needles. Right. I mean, it's really standard. And that's something that I've definitely evolved to, not recently, but, as compared to my original practice. I use short beveled needles. There's a bunch of companies that make like echo tipped ones that are, machined and textured so you can kind of see the tip really well on ultrasound. And I think if you don't have access to blunt tipped short bevel block needles, the next best would be like a 2E. Which is kind of like an epidural needle. And then after that, if you can't even get that, probably like a pencil point, something like a Whitaker, that you might use for like a lumbar puncture. So that'd be like my descending order of preference. And the cool thing about using a blunt tipped block needle or a short beveled, nerve block needle is almost without exception, they come with extension tubing. You'll open up the pack. It'll have the needle. It may have electrode hookup if you wanted to do if you wanted to measure sort of like current through it and look at nerve twitch. I don't do that. And then it'll have thin extension tubing that comes off and ends in a lure lock, so you can just go ahead and attach your syringe to the extension tubing. So back to the original question, ideal scenario for me would be like a little insulin syringe for a skin wheel, and then a 20 or 30 ml syringe with my anesthetic solution hooked up to extension tubing, hooked up to a dedicated short bevel block needle.
So wait, why are you doing the skin wheel separate?
So, getting through the skin with anything, the skin hurts probably more than anything else you're going to do. So what I like to do for any cutaneous based procedure is to raise a wheel right where I'm going to go right before I prep with sterile solution. So I do it for lumbar punctures. I do it for nerve blocks, in particularly like hyperalgesic patients, maybe like, injection drug users with opioid addiction who need ultrasound-guided IVs. I'll raise a skin wheel for those IVs. It just makes people sit still better. It's less uncomfortable, and it just makes it gets rid of sort of that procedure flop sweat that you get when patients are like, screaming and unhappy and wincing in pain. So it also is something you can prep over and you're not going to erase it. So you think about like, putting a dot on the skin with a marker for your lumbar puncture and then prepping the skin.
Gets cleaned off all the time, man.
Gets cleaned off, or you do like the back of the needle, like the part that attaches to the syringe, and you make like a little indentation, or a pen and you make a little indentation. And then it's like a race against time. Can you like prep and get draped before that thing goes away? Whereas if you just take an alcohol wipe, you're not sterile at this point. An alcohol wipe and raise a wheel, you've got your place marked and you can go ahead and prep over it. And it also kind of like bakes in the time that you need for someone to get numb, because like generally, and I'm not trying to make an exception for myself, generally we suck. We're like, here's some local anesthetic. Now I'm going to get started. And if you raise a wheel and then prep and then put a drape on, by the time you've done that, the wheels had some time to take effect and they don't feel pain. So, getting through the skin with a blunt tip needle, you need to go kind of like straight down. Like if here's your ultrasound and your approach is going to be like this for whatever your target is in plane, you're going to need to pop through the skin and then turn and go like that, because it's blunt. It's not a sharp needle. You're not just going to glide through. So I like having a wheel of local for that. And then I'd have, probe in my non-dominant hand, needle in my dominant hand held at the hub, get through the lidocaine wheel into the tissue, inject just a tiny amount of local anesthetic, because otherwise there's always just that little blip of air that you never got rid of.
Yeah.
And then
Everything up.
advance,
Can't see anything.
and then and then you ruin your image, and then advance towards the target. And if you have an assistant, being able to just say aspirate, you're looking directly at the needle because it's right in front of you for any blood in the extension tubing. Okay, inject, and then you're looking at the screen and looking for spread around your target. That's kind of an ideal scenario. We have resources in my emergency department. It's a community hospital. There's usually a nurse or a tech if I want somebody to come and help out. And people do tend to get a lot out of being part of the procedure, and it's educational for them, and they enjoy participating and injecting. The other thing you can do is just let go of the needle. It's not going to go anywhere. You're looking at it with ultrasound. You can pick up your syringe and aspirate and inject, and then you can reposition the needle. And there's also people talk about like this. There's like a Jedi grip that's been described in the literature of like holding the block needle between two fingers, and then your syringe is here, and you're aspirating and injecting at the same time.
Interesting.
I mean, if that's your bag, it's awesome. I'm not trying to disparage it. It seems a little bit awkward to me in terms of how to hold it. And I've definitely let go of the needle hundreds of times, aspirated, injected. It's a blunt needle that's like in tissue. It's not just going to flail around and go lacerating everything. And you're looking at it with ultrasound at the same time. So that's my ideal setup, I think, is blunt tip block needle extension tubing, and either an assistant or yourself aspirating and injecting.
Are you using like a sterile sheath cover and like sterile gloves, or are you doing like kind of like how we do IVs, which is like maybe clean it with the purple or the gray wipes? Probably the gray wipes is better. A Tegaderm, sterile lube, and gloves. Which way are you going?
Yeah, I'm sort of, I guess what would count as kind of semi-sterile. And this is not evidence-based. This is just based on practice that I've seen from some of the anesthesiologists who had a role in influencing my practice. So alcohol wipe for the non-sterile entirely for the pre-scan, non-sterile gloves, alcohol wipe, skin wheel. That's all non-sterile. And then chlorhexidine skin prep. I'm not putting a drape on most of the time. Sterile gloves, either an adhesive sterile probe cover or a probe sheath, and then obviously a sterile needle. But no, I'm not gowning, masking, or putting a cap on, and I'm not draping the patient like head to toe. I think if you're, in general, I think the exception to that would be if for some reason in your practice you're placing catheters for continuous blocks. Sure. If you're doing that, I'd treat it the same way as a central venous catheter. You're putting a foreign body into the patient that's going to stay there for an unknown period of time, and that's like a full body drape, full gown, mask, the whole deal. If you're just needle in, needle out, I mean, you think about how we do, joint injections or aspirations, and if you go to like a sports medicine practice, there's nothing sterile. I mean, some people are just doing like alcohol wipes, but like at the low end, you're seeing like, non-sterile gel. The ultrasound's just not touching the part where the needle's going. A little betadine on the skin, and then needle through the betadine. And again, nobody's studying this, right? It's not like you're going to go to a sports med clinic and do like a longitudinal, prospective study on randomizing people into like getting fully prepped versus not. That just doesn't happen.
Right.
But we also don't see like an epidemic of iatrogenic septic arthritis from this practice. So I think it's probably safe. But to me, sterile gloves, skin prep, and something covering the ultrasound probe that's also used for like abscesses and like whatever else. I think that's probably good. That just seems like that's what I would want if you were going to block me. So that's what I do for patients, but not based on any sort of like great evidence.
Cool. What about some advice you might give somebody who is, let's say, Mike Stone, it's you, and you have never done a nerve block. So you're an established physician, you're well out of residency. How would you give yourself the advice about how to start? Like where to start, basically, if you have no experience whatsoever, nobody does it where you work.
Yeah, I appreciate you saying well into practice or well out of residency instead of old. That's very kind of you. I think you start with like what we will often among each other like refer to as gateway blocks. So you start with blocks that are easy to perform in the sense that they're not technically challenging, that they're generally associated with low volumes of local anesthetic. So you're not even putting local anesthetic systemic toxicity into play as a possibility. And that are for things that are otherwise problematic or stressful or less than ideal in your existing practice, and you're not kind of looking for new applications. So to me, those are ankle blocks, forearm blocks, and superficial cervical plexus. So ankle block, really just getting the tibial nerve at the ankle. It's great for pain control for calcaneal fractures, and it's really it changes the plantar forearm body or abscess or laceration from this like super painful, miserable experience for somebody into a totally pain-free, like great ER interaction. So that, and it's a block that we would consider doing already based on an anatomic approach. It's just that the anatomic approach doesn't work that well. So, so that's an easy one to get into. It's not out of our comfort zone. It's just an ultrasound version of the block you're already doing. So that's just incorporating ultrasound for placing central lines. Some of us were placing central lines before ultrasound, and now it's just a way to take the thing you already do and make it safer, and more successful. So, so that'd be one. Forearm ultrasound nerve blocks are another one where, painful injuries to the hand, whether it's like a boxer's fracture or a palmar laceration.
What about a gunshot wound to the hand because you forgot that there was a bullet in the chamber while you were cleaning it? That's like the most common thing that happens.
Kentucky? Is that what we're talking about?
That's like the most common gunshot wound injury, like where I work, unfortunately.
Yeah. I mean, they, yes, great for pain control for that as well. Just not to be too provincial, people in Oregon love their guns too. So we definitely see those. The nerve blocks at the wrist, median, ulnar, radial, work reasonably well. We have some literature that I'm biased in because one of the fellows at Highland did this while I was there, and I helped out on that study, where we kind of randomized people to a wrist versus a forearm ultrasound-guided nerve block. And there's definitely it seems like it's more effective with the forearm approach, and it's also just subjectively way less painful, right? I mean, you think about how our bodies are innervated and like tips of the fingers, so much more so than like deltoid. And it just basically decreases as you come up. So if you're doing mid forearm, that's just a lot less sensitive than doing the wrist. So that seems to be an easy gateway block for people to get into because it's a common injury. We see stuff to the hand all the time, so you have a chance to practice it. And it's just a way to get more comfortable, with needle placement and anesthetic administration. And then superficial cervical plexus block, if you're doing internal jugular central venous catheters, or you take care of patients with ear lacs or clavicle fractures, which any practicing ER provider does, easy block, less than a centimeter under the skin, usually 5 millimeters or less under the skin. And it's really, I mean, you've done this. I know you do this for your IJ placements. Just another good example of the whole timing of it though. In terms of a wheel. So if you're pre-scanning somebody for a internal jugular line, which you should be doing, so you don't end up going on the side that's the small vein or the one with the clot or whatever. If you just do a pre-scan non-sterilely, select your target, take an alcohol wipe, put in a superficial cervical plexus block with 5 to 10 mLs of anesthetic, and then go get all your stuff going, put the sign on the door that's like, we're doing a sterile procedure, the whole prep, the drape, the gown, get your kit out, flush your syringe, all that stuff. By the time you stick the neck, it's been a solid 2-3 minutes, often more. That patient's completely numb, and you can stick, you can dilate, you can, use your scalpel to make room for the catheter, and then you can sew it in, and they're completely pain-free. And again, it's just, how do you show a research-based outcome that can convince you to do that block? It's kind of challenging, but once you've placed a IJ in somebody who's completely anesthetic and is talking to you and like just no wincing, no moaning, no discomfort.
Right.
It's a totally different procedure, and it's way more enjoyable for the doc and I'm sure for the patient.
Yeah.
So those would be that'd be sort of like my how to get into doing blocks.
Mm-hmm.
And then I actually I don't want to sound preachy, but I do think that if you're not considering blocks for hip fractures like femoral neck, intertroch, subtroch for elderly patients with those fractures, I think you're probably not practicing current management of those patients in the emergency department. I think that you can give them opioids and you can slowly depress their mental status, but we know that that regional for those patients decreases opioid utilization, decreases in hospital like catheter associated UTIs, decreases delirium. Like it's the right thing to be doing for those patients. And sometimes it feels like, even in my practice, like when things are busy and I'm seeing 3.5 patients an hour on a night shift, the last thing I want to do is go drop a femoral block or a fascial iliaca block into my 80-year-old who kind of seems okay if they're not moving and already has an admission and a disposition, but it's the right thing to do. It's just going to increase the downstream experience for that patient. So once you're kind of comfortable with, here's a needle, here's some anesthetic, that's what a nerve looks like, and you get started with whether it's ankle or SCP or forearm, I think learning how to do a fascial iliaca compartment block or a femoral nerve block early on is a good strategy.
Yeah, and I think that what happens sometimes too is I think people get kind of worked up on the whole, oh, it's going to take me a little bit more time to do this. But if you kind of think about all the resources that you're wasting having to give the patient more narcotics, talk to them some more, give them more narcotics, the nurse comes and gets you because their mental status is different, but they're still screaming in pain. Like if you kind of put all of the time together that it takes to not do that fascial iliaca compartment block versus doing it, I think that it's actually faster overall to actually just do it, even though it seems like it's taking you a lot longer in the moment. In the whole shift, it's way faster, I think, and way less work.
Oh, and 100%. It probably translates patient to patient, but it definitely translates for like that 1 out of 8 or 10 patients where the nurse grabs you because now they're hypoxic and now and somebody felt like they were still in pain, so they gave them some benzodiazepines because they thought it would do like muscle relaxation. And you've got this 80-something-year-old who's now had like fentanyl or hydromorphone and a little bit of lorazepam, and now they're just obtunded. It's like completely preventable. I mean, it's just not something that has to happen. Other thing I'd say, just because it crossed my mind, is really short-acting anesthetics. That was something I wasn't doing maybe 10 years ago. No, so lidocaine is okay. Lidocaine is a pretty weak regional anesthetic. If you're going to use lidocaine, if you're able to do 2% based on dosing and safety margins, and again, like safe local is a great thing for that. 2% tends to work better than 1%. But for ultra short acting, like 3% 2-chloroprocaine. So that's an anesthetic that
use that.
And most ER docs haven't. It's stocked in your hospital because it's still a pretty popular medication for epidurals in a continuous form. So they'll do continuous infusion through an epidural. It hasn't really found a home in regional anesthesia in the operating room setting, because it's extraordinarily short acting. I mean, it's like onset in maybe 5 minutes and offset in maybe 30 to 35 minutes.
Wow.
So it's this super short acting anesthetic. The cool things about it, other than the pharmacokinetics, are it's an ester. It's not an amide. So it's it's again about like counting the number of eyes in it, and is it an odd number or an even number, right? So it's like a Novocaine, right? And it's slightly higher allergic reaction potential as compared to the amides, but still a really low. I mean, you think about how long people used Prilocaine or Novocaine, so not Prilocaine, Procaine or Novocaine, because those are both esters. The other thing that's cool about it is because it's an ester, it's cleaved by acetylcholinesterase. So if you get it into the blood, I can't say it's impossible that it would cause local anesthetic systemic toxicity, but it's hard to imagine how it could, because you have serum acetylcholinesterase that's breaking down your ester. So it's hard to get to really toxic concentrations.
Interesting.
The reason it hasn't caught on with in the operating room is, like, if you're an anesthesiologist doing a regional block for, say, a shoulder surgery, and you put an interscalene block in with 2-chloroprocaine, it would be off by the time the surgeon was in the middle of their surgery. Like, it's too short acting.
I see.
But for us, you think about a lot of I think you can break the procedures we do down into 2 categories. One, something that you're doing for ongoing pain control, or for a procedure that's still going to be painful when you're done with it. So, like, if I incise your big deltoid abscess, it's going to feel better when I'm done, but it's still going to hurt. Right. If I'm, and on one end as a procedure, on the other end, if I'm doing a fractured neck of femur for an old person, all I really care about is duration and pain control.
Right.
So in all of those categories, the long acting pain control or the long acting pain control after you've facilitated a procedure, I go with either ropivacaine or bupivacaine, depending on what's available. And I'm going for, like, the longest duration possible. Then there's those things that are, like, super quick. Like, maybe you've got an elbow dislocation, and for whatever reason, like, you don't want to go intra-articular, or maybe you've got, the classic example would be like a glenohumeral dislocation, right? So you've got a shoulder that's out, you want to put it back in, for whatever reason, like, they're the 1 out of 10 patients that you can't talk it back in, or, like, just manipulate them and get it in. If you do 2-chloroprocaine, they're numb in like 5 minutes. You pop it back in. By the time their X-rays done, or they've gotten their sling, their function's back, and you've got this, like, super on and off thing. Especially if you're thinking about doing something short in, let's say, somebody who was like a COPD patient who's home oxygen dependent and has a glenohumeral dislocation that you can't get back in. That's a nightmare patient to be sedating, right? They're already sort of oxygen dependent at baseline, and you don't really want to be worrying about their airway. But you also don't want to do, like, a lidocaine or a bupivacaine interscalene block and potentially take away their diaphragm on one side.
Yeah, that's a bad idea.
So being able to do something super short is a nice option. And I'd say that, I probably really only use chloroprocaine for glenohumeral dislocations. And it's a pretty rare occasion that I can't get somebody in by talking to them or just like slowly manipulating them. But when I do have to go to regional, I like that for that. And that wasn't something I was using or familiar with before that. So I would say, and then the last thing to plug for like anesthetic selection and learning about this stuff is the Highland ultrasound site, which
so
we can link to. There's a great table that gives you sort of, if you don't want to go through the safe local exercise and you want to just go, 50 kilos, 70 kilo, 90 kilo person, they've got columns for that, and sort of each anesthetic solution and concentration and what a safe dose would be. And I think they have, I'm pretty certain they have chloroprocaine in that list as well, so you can get some dosing recommendations.
Those were phenomenal tips, Mike. Thanks so much. Now, what can people do if they want to learn more about ultrasound in general, learn more about nerve blocks via maybe a fully online kind of mentorship, maybe fellowship program?
Sounds familiar. I feel like there might be something out there.
Right.
Are you talking about Ultrasound Leadership Academy?
Yes, I am. The thing that you started and you run.
Yeah, so ULA is Ultrasound Leadership Academy is a nonprofit organization that does essentially like distance tele ultrasound fellowship training. Now multiple options from like 3-month to year-long programs, and you can go to ultrasoundleadershipacademy.com. If you're interested in the shorter programs, you can go to ulamini.com, MINI. And yeah, we have the good fortune of having maybe 40 different ultrasound experts, yourself included, on the list of faculty who can help train folks as they go through that sort of critical experiential phase where they're learning ultrasound and trying to incorporate it in their practice and become experts on their own.
Brilliant. And then if they want to hang out in person and maybe get some experience in person with you and with a bunch of other ultrasound experts from around the country, where are maybe 2 conferences they could maybe think about?
I think if you generally just go and look for an ultrasound conference that ends in the word "fest," you're gonna be pretty safe. So you're in charge of setting these up, but I think we're on track for both Bend Fest and Castle Fest in 2020. Is that right?
That's right. Yeah. So the URLs are castlefest2020.com. That's going to be May 5th through the 8th of 2020. And then May the 4th, we're going to have a pre-conference workshop where we do just a quick course on ultrasound-guided vascular access, one on how to do this, how to create media with electronics, I guess, and then the ultrasound management course. And then there's also going to be another conference in Bend, Oregon. The URL for that one is bendfest20.com, and that conference is going to be in July. Hope to see you all there.
Awesome. Yeah, come out. Oregon in July is about as good as it gets.
Agreed.